This meeting is being recorded.
Hello, so my name's Sandra Roberts and I'm an emergency nurse practitioner in Ysbyty Gwynedd in North Wales in Bangor in the emergency department, and I'm also a part-time lecturer in nursing for the Bangor University as well, which is quite a new role for me. So welcome. We've already met Kira and Adam, and hello Mark, you just joined. So welcome. So where are you based, Mark?
I'm from Skegness.
Oh,
so I'm
right.
an emergency care practitioner in Skegness Urgent Treatment Centre, and I work for the ambulance service as well.
Oh, right. Lovely. So we've got Kira is a nurse practitioner in Northern Ireland. And then Adam is specialist ambulance practitioner in Somerset. So, and then we've got Judith, who's the who's from the faculty of emergency nurse, but her background is consultant nurse as well. So yeah, so there might be some others joining. Still a bit early, but I'll make a start because it is the evening and it's probably our evening off. So, going to be talking about the red eye. What a classic red eye is, and then what things when patients say, "Oh, I've got a red eye," and it's not really a red eye, but they describe it like a red eye. So I'll just share my screen. Hopefully this will go to plan. There we go. Right, so I can't see you now, so I'm just relying. Is that coming up with red eye?
Yes, it is.
Oh, lovely. Okay. If anything happens to the slides or they stop, because sometimes they still move for you, and sometimes they've stopped, just let me know. If you've got any questions as we go along, or even if you've got any of this information that I'm giving, you know differently, or you've got more update knowledge, then please let me know, because that'll be great. So we can share our experiences as well. So yeah, talking about the red eye. So I'll go on to the next slide. Oops. So because I wasn't sure what all our experience would be, because we do have all different people coming along and who've got different roles, but we'll just do a quick A&P revision, and it's always quite good to refresh. So hopefully not going to get too bogged down with this. So obviously the eye, it's an organ of the of sense of sight, and it's supplied by the optic nerve, and it's about 2.5 centimeters in diameter, and it's almost spherical in shape, and it obviously sits in the orbital cavity, and that's surrounded by a nice protective layer of fatty tissue to help cushion the eye. So we have our eyebrows, which are there to protect and trap the dust. They can catch foreign bodies and also sweat.
Sandra, can I just stop you there? You were you're not moving the slides on the screen.
I'm moving them on. So
yeah, they're not.
Yeah.
If you could try using the presentation, that might work.
Okay.
Rather than just the slides. Try going to presentation.
Right, let me go back. Are they moving?
No, it's
No.
still on your home slide, your first slide.
Right. So I've gone on to just presentation. Will they move like this?
There you are, now they're moving.
Yeah, is that okay like that?
Yes, yeah, that's
yeah,
fine.
because when I go on, sorry about that. So yeah, so obviously so the eye, like we're saying, is the organ of sight supplied by the optic nerve, and yeah, about 2.5 centimeters in diameter, and it's in the orbital cavity, which is protected by the fatty tissue around it. So the next slide here is just showing you the eyebrows protect the eye by trapping dust. It catches foreign bodies and any sweat as well, stop that dripping into our eyes. It the lids, the eyelids and the eyelashes also protect from injury and prevent the eye from drying. So it's automatic. If someone's coming towards you or something flies at you, that your response is to shut your eye to protect it. So the tear ducts, which you can see, which is on the presentation there, that they're there, they produce salts and waters and also some bacterial enzymes, and they wash away any particles, but they also help to prevent infection because of the bacterial enzymes that are in there. And then we have the ducts that drain away the tears. And when we have an irritated eye, it produces more tears, and that's when we get quite a watery eye. So there are 3 layers of tissue to the wall of the eye. So the outer fibrous layer is called the cornea and the sclera, and then we've got the middle vascular layer, and that's comprises of the choroid, the ciliary body, and also the iris, and then the inner nervous tissue layer, which is in the retina, which I'm sure we've all heard of. Let me go down my slides now. So there's just the eye, just for a refresher there. So the white bit is the sclera, and the black bit in the middle, pupil obviously. We've got the iris and the conjunctiva layer, and then obviously the eyelid there. I'm sure we all know that. So a little bit more detail about these. So we've already discussed that the sclera is the white of the eye, and it's quite tough, and it continues as a transparent film layer, which allows the light to pass through and reach to the retina. We then have the iris, and this contracts and relaxes. This adjusts pupil size to allow lights to come in. It just depends on how many pigment cells that you've got. That determines the colour of your eye. So blue do have fewer, and brown have more. And I do believe that green eyes are the rarest, one of the rarest colours that you'll have. So this is both parasympathetic and sympathetic as well, with the reaction of the iris. So the pupil, which I'm sure you all know about pupil, hole at the centre of the iris, and it dilates and contracts, regulating the light through to the lens. And then the limbus is the black ring that's around the iris where it meets the sclera. And it is said that if people have a very obvious black rim around their eye, the limbus is very dark, then they're supposed to be more attractive. So you'll have to have a look later and see what your limbuses look like. So the conjunctiva, so we've got 3 different parts to the conjunctiva, which you can see there: the bulbar conjunctiva, the palbar, I can never say this, palpebral conjunctiva, and then the fornix there. And it's a clear tissue. It covers the eye and the inside of the eyelids, and it keeps the eye lubricated and protects it from dust, debris, microorganisms, and and infection. And this is the layer that gets inflamed with the conjunctivitis and gets quite red. So you have the eye that's divided into 2 chambers. You have the anterior and the interior, and the interior chamber is full of vitreous humour, and it's quite a clear, thick substance, and it supports the shape of the eye, and it also lets the light through with it being clear. So you can see on the diagram there, that the anterior chamber is at the front of the eye, and then the interior is at the back of the eye, with the lens dividing the 2. So the lens, it's highly elastic, and like I say, it's just behind the pupil. It hangs off the ciliary bodies, and it's enclosed in a transparent capsule. So that the thickness is actually controlled by the ciliary muscles, so they contract and relax, and that's what you know, controls the thickness of the lens, and it can bend the light rays going into the eye, so they can reach the back of the eye. And you know, I'm noticing this more and more as I'm getting older. You know, I definitely I'm aware that my lens gets thicker, you know, depending on whether things are near or far away. When you sort of look down and then look up, you can actually feel that happening. You can see it happening. So the choroid is the layer. It's very rich in blood, and that's at the back of the eye. If you can see on the diagram there, it's it's the yellow, the red bit that runs all the way around, and this absorbs the light. So it is an extension with the ciliary body. The ciliary body is an extension of this choroid, really, and it's a muscle, you know, which I was saying before is attached to the suspensory ligaments which hold the capsule of the lens. So the retina itself is the inner wall. It's very, very delicate. If you've had people who come in, which or you've seen them, I'm sure you have, who have detached retinas, and they describe a curtain-like, you know, vision in their eyes, and that's the retina with all the blood vessels sort of detaching. So it does supply blood and from the optic artery, the blood supply. And it has the nerves, rods and cones, and these are what decide, you know, on colour, really. So the fovea only has cones, so the cones see colour, and the rods, you know, don't see as much. So in that area there, which you can see is in the centre of the back of the eye, that tends to see the most intense colour, and then the retina converges with the optic nerve and passes off into the brain. Then, so you have the little disc, which is the blind spot, which is the bright coloured disc on there, where that goes in. So we're almost finished on these. So that's just a better picture for you to see how the eye looks. And then we have the muscles that attach to the eye as well. So it's always good just to have this revision, so we can see, you know, the structures of the eye. Okay. Everybody okay so far? Just going to go on to assessment and examination, and this will be something that I'm sure, you know, you're already doing, and you probably you know, are aware of how to examine and you know, assess eyes. So history taking is really important. You know, we do it in everything that we do, and we already know that, you know, it's a really good indication of possible causes. The patient comes in, they give you the history, and you're already building up, you know, possible diagnosis on that. And so it also helps determine the type of investigation that you might need, and also you would be thinking about treatments that you'd possibly need to use. So you also, you know, need to listen quite carefully to how the symptoms start, the you know, pattern of onset. Think of any recent illnesses. You can check if there's anything that relieves it. You could have a look, ask if there was anybody in the house who maybe has an eye infection, for example. So it's good to, you know, see if there's anything that's been making it worse or making it better. Past medical history, allergies, medications, with everything, that's really important. If we are giving any medications, then we want to make sure they're not going to interact with things, or that they haven't got allergies. And also past medical history, certain conditions can cause, you know, a red eye, or certain problems with the eyes. So it's always good to have that history, so it does give you clues as to what the cause of the red eye may be. you know, the normal vision as well. You know, do they wear glasses, contact lenses, the previous eye health? You'd always treat somebody maybe who had loss of vision in one eye differently to how you would treat somebody who had total vision, because their remaining eye is much more precious. So you may well have a you know, a higher index there where maybe you would refer them on, whereas maybe with somebody who had normal eye health you wouldn't. Yeah, and you know, conjunctivitis can be secondary to an injury. So, you know, because consider the mechanism, that's really important as well, because it could suggest a more serious problem. Often people will come with the red eye, but the actual initial cause is not due to maybe, you know, an infection in the eye. It could be that there's been a foreign body. So that's important to consider. So I'm just going to go through the recording the visions. So when we record our visions, we do this using a Snellen chart, and you can get ones for children or for people who are literate or have maybe learning disability. So the child ones, you know, come with pictures. If you didn't really want to use the pictures for an adult who couldn't read because they were, you know, a bit childish, then you could get ones that have symbols on them, or you have an E that's in different directions. But the one there with the letters on, if you have, you know, your patients who can actually read them, then you would use that one. Have you all done visual acuities at all? Just checking if you're all still with me, because I can't see any of you.
Everybody's still there. You've got
That's all right. You're not quite sure when I can't see the screen. I don't want to realise I've lost you. No. Thank you.
Maggie's still coming as well.
Oh, lovely. Hello. So when we record the visions, it's documented at 6 meters, and you know, you even if you're not recording it with a 6 meter chart, you can have a smaller chart, which is maybe a 3 meter chart, and this would be, the letters on this would be smaller, and you would have your patient standing at 3 meters. So even though the distance is shorter, we would still record it as 6 meters, because the chart has been made smaller to accommodate this. So it's always recorded, you know, over 6 meters. If the patient can read all of the line, because the letters will correspond to a line number, then so if they could read all of line 9 except the last 2 letters, you would record it as 6/9 and -2, because they've read everything on line 9 bar 2. If they get the majority of the lower line, then it would probably be 6/9. So they've read the whole of line 9 plus 4 from the lower line. So what can be very helpful, because you're going to have a patient that comes in with a very watery eye, and they might be a bit photosensitive, so you would maybe filter the light, and you would do this by using a pinhole eye cover, which you can see in the picture there. And so this helps to make things a bit clearer for them to make out. And quite often I will find that the visions have been done in triage, and then I repeat them with this, and they're much better. So if you were to use the pinhole eye cover, then you would record that next to it. So you'd record your visions as VA, right eye 6/9, for example, and then you would put a capital PH next to it to represent pinhole. So obviously they would cover each eye in turn, If they've got glasses that they would normally wear to read at that distance, then you'd ask them to wear the glasses. They may well have contact lenses. And if they are in, then they could attempt to read it with them in, but don't ask them to put them in to read it. If there's something going on with their eye, and then if they do have the contact lenses in, then you do need to remember that they need to be removed before you treat or examine the eye. As I said, the watering and pain can reduce the vision. So as well as filtering the light, you can put an anaesthetic drop in, and that can also improve things, because the patient can then keep their eye open, because sometimes they just can't keep their eye open to do the reading because it is so painful. If your patient can't see, you can move them forward, but you would note this down differently. So for example, if they can't see the chart at all, you could move them, get them to count fingers at a meter, and you would hold, say, 4 fingers up, and if they could read the 4, then you would put CF4 at 1 meter, or maybe if they could only see the 2, you'd put the result of how many fingers they've been able to see. If that fails, then you could check for hand movements, if they can see a hand being waved in front of their eyes, and that would be documented as a HM, and that's at 1 meter again. And then obviously if there's nothing there, then you can do perceived light, where you would be shining the light into their eyes, and if they can see that light, then it would be PL for perceived light, and if they can't see it, then it would be an NPL documented next to those visions. If this was normal for them, then it's very important to make a note that this is normal. Sometimes you will come across people who've got quite reduced vision, and it is actually normal for them, and you have a little bit of a panic to begin with, thinking that they've not done some serious damage to their eye. So the examination, obviously, we're going to follow infection control standards. We're going to explain the procedure, and we're going to gain consent, and this is an opportunity for the patients to ask you some questions as well, because some patients can be really quite nervous about having their eyes touched, and it can be quite a difficult examination. They pull away from you, and naturally they go to close their eyes. So it can be a bit tricky sometimes, and particularly with children as well. Sometimes you only have one attempt to actually be able to examine them, and then once they know what's coming, they won't let you near them again, really. So anaesthetize the eye. You can use touch cane drops, and I can't remember the name of the other one. It's gone out of my mind. Vivicaine, is it? No. Judith will probably know, completely gone out my head. The touch cane does tend to sting. The other one doesn't sting quite so much. It just depends on what your PGDs allow you to actually give, if you're not a nurse or another non-medical prescriber. So what you would be doing is looking at the eye, comparing them, note any abnormalities, if there is redness, swelling, the pupils, the reaction, the size, and also if they're irregular, they may have irregular pupil anyway. Some people do following injury or some sort of surgery, and also look for discharge. Want to see the movements as well, because some eye problems where there's a lot of inflammation, and the eye movements can be affected, and also if there's any haziness. We also look at the red eye reflex, and this would be where you would shine the torch into the eye, and at close quarters, and you would see the red shining back at you, and this is to do with a healthy eye. It's often done with children during their assessments, their eye assessments, in the early days, and if there is no red eye reflux, that does mean that there may be some sort of problems with the back of the eye. So it's not always an essential thing to do in an emergency, but it is quite useful to see that red eye reflux, because it does give you an indication, and you can maybe pick up some problems with the eye health that maybe the patient wouldn't know about. So you're also looking at the appearance of the globe. Does it look full? You know, compare the eyes. And also you would be inverting the eyelid. You'd be checking for any foreign bodies or abnormalities, you know, under the conjunctiva, in the conjunctiva and under the subtarsal area. Ensure that you've got, you know, good lighting, magnification, and possibly a slit lamp. I don't think every area has slit lamps. Certainly when I first started out, our department didn't have a slit lamp, we just had a magnification light, but the slit lamp is so much better. And probably for the paramedics here, you won't have access to that, so it's making sure that you've got, you know, some good lighting and magnification really. So to invert the eyelids, you place cotton bud on the upper eyelid and just press gently down, get the patient to look down, and you secure the lid with the cotton bud, and you pull on the lashes and fold the eye inside out, and then you may well pick up a foreign body. You can get the patient then to, you know, look up and release the eye lid, and then that will go back to normal. This can be quite difficult if you've got someone who's got a swollen upper lid or very short eyelashes, and also people with false eyelashes, because they're not very happy if you start pulling their false eyelashes out that they spent a lot of money on. This is just a little video just showing you how simple it should be. Like I say, it isn't always simple, especially when you have a patient who's in a lot of pain and is a bit worried as well. There we go. So that just shows you, you know, how you would invert the eyelid, and you can see quite nicely there that you can see the subtarsal area to check if there's any foreign bodies or any injury or inflammation there. So the other thing you may well need to do is use fluorescein stain, and this is helpful to look for abrasions and scarring also in the eye, to the cornea. And the fluorescein stain is orange. It either comes in some drops or it'll come on a little piece of paper that you have to moisten and then pop in the eye. Once it's instilled, you ask them to blink, and that spreads the stain over the surface of the eye. And then you would view that under a blue light, and what would happen is the abrasion would shine a greeny yellow, as you can see in the top picture. You can also see something called the Seidel sign, which is a sign that there's aqueous humour that has leaked out of the globe, and this would indicate that there's been you know, a more serious injury, and the eye has actually been potentially punctured there. And as you can see on the bottom slide, you have a bit of a trickle which tracks down and takes the fluorescein with it and settles it in the tarsal area of the eye, and that's an indication that there is some fluid there leaking from the eye. So obviously that would be always a referral on. So that was you know, a quick overview of treatment and examination. Sorry, assessment and examination. Apologise. Any questions at all around that, or any tips that are useful that you've done in practice when you've been examining eyes and things?
The only other thing that I can come up with, Sandra, is that you can sometimes get a lignocaine with a fluorescein drop together.
Yeah, yes.
Those before, and they are really good because it
Yeah.
saves putting 2 lots of drops in the eyes.
Yeah, that is quite useful because they do sting, and you know, and it can be, and also what you find when you put the lignocaine in, sometimes the tetracaine, they blink really quickly and you don't get a good dose in.
Yes.
So you know, sometimes it is just the once you can get things in, isn't it?
Yeah. And the other one is that you might end up with a really bad photophobia, so that even with a methocaine, you can't get anywhere near the eye to examine it. And I know they then dilate the pupil up, and that takes away some of the pain. But I think I'd be thinking about the ophthalmologist doing that, because if it's that bad, then you don't want to be messing and dilating something up, unless it's an arc eye or something.
Yeah. Yeah, and that's the other the eye anesthetic I couldn't remember, isn't it? A methocaine. I think that doesn't sting quite so much, so that's better with children, really. But sometimes you are a bit restricted as to what our policies allow us to actually administer. So if there's nothing else, I'll move on to diagnosis and the treatments as well. So classic red eye, pink eye, you know, we have conjunctivitis. And when we refer to a classic red eye, we're talking about the sclera that is red. It is the eye itself and not the surrounding structures when we're thinking of a red eye. So there are 5 types of conjunctivitis, there's 5 categories of conjunctivitis, if you like. We have the viral, bacterial, chlamydial, or gonococcal, so they're your sexually transmitted disease that can be transmitted to the eye. We have allergic conjunctivitis, and we've also got toxic conjunctivitis. And the treatment does differ slightly, so it's important to try and understand and recognise the different symptoms so you can treat these things correctly. Most common is the viral. Usually seen in adults, and children do tend to have bacterial. They're a bit more snotty. They tend to, you know, rub their noses into their eyes and things, and fiddle with their eyes maybe a little bit. So they do tend to have a bit of a discharge that you would see with the bacterial. So if we look at the viral first, and we refer to this as EKC, which is epidemic keratoconjunctivitis. And you know, it's seen everywhere. It's referred to, often called pink eye. We tend to hear that on American TV, I think, you know, pink eyes. And it can lead to corneal scarring. And if it's a nasty or persistent, you know, it can then cause damage to the vision. So it's caused by adenoviruses, which is really the most common cause. There are other viruses that can cause you know, problems with conjunctivitis to the eye, but we'll talk about them in a bit more detail afterwards. So your symptoms of the viral conjunctivitis would be a very watery red eye. You know, the sclera would be very red, very inflamed. There wouldn't really be any discharge, no sticky discharge, because there's no bacteria. It is viral, and the eyelid will be a bit swollen. There will be a gritty sensation, feel like there's a foreign body in their eye, and they will have pain when they're looking at bright lights. They may have a bit of a runny nose with this as well. So this would not need antibiotics. It's usually self-limiting, and it can last for up to 1 to 2 weeks. It is quite you know, highly contagious, so you do need to make sure that the patients are aware of the infection control, the things they'd have to put in place at home, not sharing towels, you know, discarding any tissues appropriately, and disinfecting you know, high touch areas. Also, not to wear the contact lenses if they have them until things have cleared up, and not to apply makeup, and probably, you know, any makeup, mascara that they would have used in that eye really should be thrown away, and fresh ones bought, ready for when they want to reapply them. Warm compresses can relieve the symptoms, and you know, you can get some artificial tears from over the counter just to help keep that nice and moist and relieve it a little bit. So the reason with this type of conjunctivitis that we have problems possibly with the having eyesight damage is because it can cause lesions on the eye. And these are called corneal infiltrates, and it's thought that they arise from some sort of immune response in the eye, an antigen antibody reaction, and if they are causing a lot of problems with the eyesight, then they can be removed with a laser therapy. So you can see on this slide, on this photo here, that you've got these little hazy spots, a bit like snow, and that is the lesions, the corneal infiltrates that have been caused by that reaction. And there's a little video here that just demonstrates it in a bit more detail.
Adenovirus can infect the eyes, respiratory and gastrointestinal tract. It is a very contagious illness and can be transferred by touch or even as an aerosol. When it affects the eye, it is called adenoviral keratoconjunctivitis. It can cause symptoms that range from redness, tearing, or inflammation of the eyes due to punctate keratitis, a condition in which irregularities on the surface of the cornea may cause blurred vision. Later, in the course of infection, subinfiltrates may develop, which impair the vision. These are grey to white cloudy spots that form in the cornea as a result of an immune reaction to the viral antigens. These can cause scarring and ongoing problems.
Okay. So if you have patients that are attendant with recurrent or persistent viral conjunctivitis, then these should be referred to eye clinic because of the risk of damage to their eyesight with that reaction that can happen. So if you're seeing people coming back and they're just not really responding to the treatment, and then they should always be referred on. So we'll just go on to the allergic conjunctivitis, which can be put due to several causes, but it's due to an allergen, but it can be transmitted or from different things. So you will see the eye will be red, it'll feel quite itchy, it'll be watering. On the subtarsal conjunctiva, you will see in the picture with the inverted eyelid there that there's like, you can't see it very well, but I'll demonstrate it in another slide. There's inflammation, and there's what we would call cobblestones, where the conjunctiva, the subtarsal there is quite lumpy. Often seen, in hay fever season. There's sneezing and it's accompanied by a runny nose, and some people, are guaranteed to get this in the hay fever, and then they take, as we know, they take their antihistamines regularly during that time. We can see swelling to the sclera as well. I don't think you can quite make it out properly on the other picture with the blue eye there. But there's the chemosis, which is swelling of the actual sclera. You can just about see there. Have got a better picture later on, and that can often be due to direct transference of the allergy. So it's on your fingers, when you touch your eye. It's self-limiting. It usually resolves over a matter of hours. You remove the allergen and things will settle down. You'd always consider, you know, your ABC, your anaphylaxis, also, if there was something going on with an allergy. But treatment, you know, would really be antihistamines, and like I say, removing that allergen. So along with these types of conjunctivitis, we have some others. So we have vernal keratoconjunctivitis, which is quite a severe allergic condition, and it's often seen more in hot countries, and it affects boys really. They're not really sure the etiology of this, but they have found that it's quite a severe reaction that does happen, you know, in hot countries. You have the seasonal as well. So this is your hay fever really. So you can have the two different types would be the seasonal allergic conjunctivitis and the perennial allergic conjunctivitis. So they're divided into sac and pack there. And common causes for the sac would be grass and pollen, and then the pack would be you know, animal hair and dust. And then we have our contact allergy, CDC, and these, you know, from things such as poison ivy, nickel, latex, etc. So that's how they can be divided down. So treatment for all the allergy conjunctivitis would be avoidance of the allergen, antihistamines, possibly steroids, steroid drops and lubricants as well to help ease any soreness or dryness in the eye. Any questions at the moment? Okay, we'll just move on then. So we also have atopic keratoconjunctivitis, AKC, and this is a dermatitis of the eyelid, and you get quite you know, nasty dry patches there, and injection of the sclera, where it's very of the conjunctiva, where it's very red and inflamed and quite vascular. So the it can be range from mild to severe, and you can also get some scarring as well on the conjunctiva, and as you can see, that looks like quite a sore, nasty presentation there. So that would be treatment with atopic steroid cream, and you may well, you know, want to give them something to lubricate their eye as well. And then the giant papillary conjunctivitis, GPC, and this is very similar to the vernal that I was discussing that happens in the hot countries. And these are the cobblestones really type of appearances that I was talking about earlier that you would get in the subtarsal area. So when you inverted the eyelid, you know, if they've got a nasty conjunctivitis or allergy, you might see this appearance. Often associated with contact lens usage, and it feels maybe with foreign body, and as well post surgery. So sometimes if they've had sutures in, and the sutures can react, and that can cause this as well. So we'd have antihistamines, steroids, cyclosporins, and if they're using eye contact, it's recommended that it's a non-preservative contact lens solution, because sometimes if you've got one that's got preservatives in, this can cause this reaction as well. So we also have keratoconjunctivitis sicca, which is dry eye syndrome, which is the DES. And this is often associated with the autoimmune or a systemic condition. So either the tears will evaporate too quickly, so it doesn't allow the eye to be lubricated, or there is abnormal tear composition, so it doesn't produce enough tears either. So it can be due to you know, a couple of reasons there. So again, it would be gel tears. What can happen as well is they can put something called the punctum plug, and that just goes into the where the lacrimal sac is, where the tear duct, and plugs it, and that just stops the tears from draining away and keeps them around the eye, lubricating them a little bit more. And then the other we have here, we have superior limbic keratoconjunctivitis, which is chronic inflammation, and it's from friction, so from the eyelid, and it causes microtrauma. And you can see on this, it sort of splays out from the limbus. And that would be corticosteroid drops and artificial tears as well. So there's a few things with conjunctivitis and red eye. So the next one we would look at is the toxic conjunctivitis. And this is damage to the tissues from preservatives, or in medications really, and the eye becomes inflamed, and this can be quite chronic. I think I've certainly seen older people who come in and they have red eyes, and it looks quite sore. So you can get hyperemia, which is when the eye blood vessels are engorged, as you can see there with the redness, and chemosis as well, which was the swelling of the sclera. Once the toxic agents stopped, the eye drops, then it usually resolves, but it can prove a little bit difficult in patients who maybe really need that type of drop and there's not an alternative. You can find some patients will go through quite a different quite a few eye drops until they find the one that obviously doesn't cause them this problem. So just to compare here, so we're going to go on to talk about bacterial conjunctivitis, is showing the differences. So this chap here at the top, that's a really nasty case of conjunctivitis there, and it's quite a purulent discharge there. It's very sticky, looks very unpleasant. And again, there's a child there with the bacterial conjunctivitis, and it's just so we can compare that with the viral conjunctivitis. You don't get any of this discharge. So that was just a little slide to compare there. Everybody okay?
Yes, thanks.
Yeah. So we have bacterial conjunctivitis, usually caused by Staphylococcus or Streptococcus, and you would get your classic red eye, red sclera. It'd be irritable, it would feel irritated, and it would feel quite gritty. It feels like there's something in the eye, and you would get a discharge as well. They may just report that they've woken up and their eyelashes were stuck together, and there might not be much evidence of it by the time they get to you. But they will report that they have quite a sticky eye in the morning. So you'd give antibiotics such as the chloramphenicol eye ointment or fusidic acid there, and you advise that if things get worse, then they will to come back for follow-up. Otherwise, that you don't need to routinely follow these up, and that's the treatment. So you've got the risk of cross-infection. So again, you with the viral, the one that was quite contagious, you would make sure they're not sharing towels and etc., not using their contact lenses until it's all cleared up. So the other one that would produce these like cobblestones and the subtarsal would be chlamydial or gonococcal conjunctivitis, and this is obviously it's usually genital to eye contact with hand. If somebody's got a sexually transmitted disease, one of these diseases, and so it's transferred. The bacteria is transferred to the eye. It's a very similar presentation to bacterial. But it's quite likely maybe to be chronic and quite persistent. So this is another reason why, if you have somebody come in with persistent conjunctivitis, then that you would need to refer. It could be something else going on. If you have quite a lot of discharge from these, from any eye bacterial that looks like it's bacterial, if you have any discharge, you can take swabs from them if you're suspicious that it's something more than just a bit of bacterial conjunctivitis. With newborns, you can see it with newborns. They may well contract that in the vaginal passage, you know, it's always useful to ask if patients, if you're really suspecting this, if they've got any other symptoms, you know, any discharge from the genitals, or if they've, you know, if any partners and things that they've, there's been any reports to them that there's been any sexually transmitted diseases. So unfortunately, if children do present with persistent bacterial conjunctivitis that it's not clearing, then we do have to consider whether there's some child abuse there, unfortunately. So that there's always just to be mindful there that there could be something going on if you've got a little one that's always coming in with nasty bacterial conjunctivitis. So treatment for this, you would take swabs and refer them to the gum clinic. So we would treat the eye with chloramphenicol, and probably, you know, for if they've got sexually transmitted disease there, you know, we'd also give them some oral antibiotics as well. Newborns would need to have IV antibiotics and an ointment, because if this is left, you know, untreated, not treated a little bit more robust, then it can lead to lung infections and possibly blindness. So with newborns, any conjunctivitis with newborns should always be referred to the eye specialist. So we just move on to ulcers now. So you can get quite a red eye with an ulcer, because, you know, it does get quite irritated, and this can be it's seen quite often with contact lens use. People don't clean the contact lenses properly, or use the right preservatives, right solutions, and they can cause bacterial ulcers. It would look quite hazy, like this one at the top here. You'd see that ulcer. So it can be a bacteria or a fungi in the eye. It could be a virus, so it could be herpes. And this is the one where you kind of look, as you can see here, it looks a bit branchy. It's a dendrite ulcer, which is caused by the herpes virus. You can get it through injury or dry eyes, or it could be caused, you know, from a chemical. And immunosuppressed patients are, you know, at higher risk, and if it's not treated, then it, you know, it can go on to cause problems with their eyesight. So these would be referred to ophthalmics. Treatment would depend on the cause. So, you know, antivirals, acyclovir, if it was herpes, for instance, antibiotics, if it's bacterial, chloramphenicol, and possibly oral antibiotics as well. And then if it's a fungal, then natamycin, or can't say that, amphotericin. Can't say that, these big words. So it's really good if you have a little look in the Moorfields website, and they've got some really nice charts there that go through what we should be prescribing for certain eye complaints, and it's quite interesting, and it's up to date as well. They refresh it and renew it, so it's always good. You can get that information, the recommended treatment. And obviously pain relief and non-steroidal anti-inflammatories as well, to help with the inflammation, which is useful really in any inflammation of the cornea. We okay to carry on? Nobody's needing a quick break or anything? I don't know whether you break, Judith. Do you?
Entirely up to you, Sandra, and what everybody else wants. Either wants to go on to finish or want a 10-minute break.
I'm quite happy,
Put,
but
put your thumbs up if you want a break. There you go. No thumbs up, so no break.
No thumbs up. Okay. So sunburn to our eyes. So we can get sunburn to the cornea. It can become quite inflamed, and it can lead on to some conditions such as cataract and macular degeneration, and also eyelid cancer. It's quite gritty. You get a bit of a headache, your eyes are quite red, so you might have a bit of swelling as well around the eyes, and you can be quite sensitive to the light. You can have pinpoint pupils as well, so it just goes away on its own. But you might want some cool compresses, artificial tears possibly, and as with most things, skip your makeup and your contact lenses until things have settled. Bit of pain relief and a good pair of sunglasses. So we just move on to episcleritis. It's not, the cause isn't completely known, but it's inflammation beneath the area of the conjunctiva, and you can get a bit of a nodule as well, as you can see in that picture in the centre. There's a bit of a nodule there, you quite often see that. You get a bit of a dull ache as well. Your pupils are normal, and your visions really, but people with rheumatoid arthritis are quite prone to this, and it usually settles with oral non-steroidals, and you would get ophthalmics to follow them up, especially if things aren't improving. They may well need some steroid drops as well. Then we have scleritis, and this is a little bit more of a severe inflammation of the sclera as compared to the episcleritis. So it's quite a lot of pain with this. It's quite severe. It can be connected with rheumatoid arthritis again, or lupus, and connective tissue disorders. As you can see on here, you've got a very, very red sclera. And you've got quite a raised nodule there. It's looking very, very inflamed and painful, and this can actually lead on to perforation of the globe of the eye. So this is a big red flag really. That's a referral. So if you see an eye that's looking very, very unhappy like that one, then that would be referred on. It looks quite milky, doesn't it, compared to the scleritis, episcleritis, when you look, that you can see the vessels quite clearly there. But in the scleritis, they kind of all merged into one, if you like. And so you can have anterior uveitis. And this is often associated with systemic diseases, and this is inflammation again. So you can get this with ulcerative colitis, sarcoidosis, AIDS, and Behçet's syndrome, which is unknown origin really, but that causes quite painful ulcers in the mouths and the genitals. So you can get it with that as well. This would be quite painful. The patient may well have had this before. Quite often they will come in and they'll say that they've had this before. They'll have photophobia. They'll have some watering. They may report floaters. And the eye is very tender, even when you palpate. When you palpate the eye through the lid. Visions may be decreased, and also shining light into the eye. The good eye will cause pain in the bad eye as we get that reaction, refractory reaction there. And the pupils usually quite small and a bit sluggish to react there. So this is a referral. It will need steroid drops, analgesia, and investigated really. It can also be a response to trauma. So this is where you know, your history is really important, you know, any mechanisms that they may have had, and also, you know, any existing diseases that they have, which would give you an indication. So if you get someone come in with quite a red eye and they've got a history of ulcerative colitis, then, you know, you may well be thinking, was this a uveitis? So we have acute glaucoma. So acute angle glaucoma, and so the angle between the iris and the cornea, where there is space for fluid to be draining through, becomes squashed because of inflammation, and this causes a backlog, if you like, or pressure against the inner chamber, because the fluid here, which would normally you know, trickle out as more vitreous humours being produced, can't escape. So there's a backlog of pressure, and this can cause intense pain. Patients can have nausea and vomiting with it as well. Pupils can be you know, dilate, and they can sort of see halos and things. It's usually in patients who are over 50, and there's no real response to light when you're examining them. So this would need IV antibiotics, IV acetazolamide. Yes, steroids. So it has steroids and also drugs to bring down the pressure in the eye, and that helps to relax the spasm and the inflammation to open up that the canal, so things can drain out again. So urgent referral, same day referral. But is there anything else you would treat that with, Judith? You come across?
Sorry, say again.
Would there be any other ways to with the acute angle glaucoma? Is it the drugs that to bring down the pressures, or would they do anything else with them? Do you know?
That I'm not sure of, because my expertise is not in this side of things. I mean, I do know that they will sometimes watch acute glaucoma because you can get it after you've had lens replacements and things, can't you? So it's one of the commoner side effects, and I don't think they always do something. But I honestly don't know within the acute ones whether they do anything other than that.
No, I don't think I've ever really seen this, to be honest. Not something tend to come across. I think sometimes
this tends to be picked up, doesn't it, with post-surgery with ophthalmics, or it's something that somebody will go to their opticians with because they're getting headaches, or it'll be picked up when they're doing the pressures on the eyes.
Yeah.
And hopefully they will prevent now, because people are having eye tests and having pressures done. The idea is that they will pick them up early.
Yeah, and I think with it being associated with nausea and vomiting, it doesn't end up coming to the miners tray, or because I'm lucky enough to be in an ED where we are streamed, so it would probably never come over to me. Has anyone else had experience of caring for these types of patients?
No.
No. I was hoping somebody might have better knowledge than me. That was one I had to look up. So just showing you, this is just a nice little chart that got off the Google, which shows you different eyes, you know, and what you would expect to be finding with each of them, because some of them can look quite similar to each other. So it's not always that easy to differentiate between them. So that's just a nice little chart there that sort of reminds you really. I'll just carry on if you've seen that. So foreign bodies, you know, can cause a red eye because of the irritation. This can be a bit of dust, bits flying in the eye, you know, maybe from grinding or hammering. So if you do have a history of a foreign body, just consider the mechanism, because if there is anything that's high velocity from maybe chiseling and things like that, it may be that the foreign body has flown in, you know, into the eye and gone through into the through the cornea. It may be, you know, that it might need an X-ray to make sure that it hasn't, you know, gone further into the eye and you can't see it. So there's a really clear history of some high velocity cause, then you may well need an X-ray of the eye to check. So you'd always look under the lid, as demonstrated earlier, to check for a foreign body. Quite often people you know, will say they can feel it under the eyelid, and when you invert it, you sometimes you're quite lucky and you pluck it out with the tip of cotton bud, and it's great relief for them. Sometimes even when you remove the foreign body, they still have that sensation, and that can be because the foreign body's left you know, an abrasion. It could be that it's come out already and it's left that abrasion, and that's when you'd be using the fluorescein stain to have a look. And you would see in this blue picture down here, there's a nice little scratch there on the eye, where somebody, you know, has obviously had a foreign body and maybe they've rubbed it. That could possibly be somebody's been poked in the eye with a nail, possibly, you know, with a fingernail. Sometimes
Sandra, one big point of interest about the cotton bud is I once had a complaint put in by the sister from an ophthalmic unit because we'd used a cotton bud. Now I know it's standard practice, but if you are using cotton buds, you should get the ones which have got a point on them. So they've got a pointed tip rather than just the standard rounded cotton bud, if you can.
Yeah, so what I tend to do is if I see that there is a foreign body in the tarsal, the subtarsal, I will pick that off with the pointed cotton bud. If it's on the cornea, then I would be using a needle, and it's because you can, because the cotton bud is quite big, you know, you can cause more of an abrasion by using the cotton bud. And I also tend to moisten it as well, moisten the tip, which does help a little bit. But
yes,
yeah,
definitely.
body removals, you know, if you're confident and you can and you're able to, then it's much better with a needle, because with the slit lamp, because you can just flick it off without causing too much you know, damage then.
One way of practicing is on a hard-boiled egg to get the needle off if you're not used to using it. Practice on it with a hard-boiled egg.
Yeah, it's the coordination I find sometimes, because you're looking through the lens of the slit lamp, but the magnification is brilliant, you know, and it's so much easier. So these pictures might be a bit small for you to actually see, but on this one with it, where I've got the rust ring, so you can have you know, a little ring of rust left where a metal foreign body's come out, and that can cause some irritation, and it is literally like just a little ring of rust. And I'm sure you know, some of you have seen that. Now, what we generally do is you'd give that chloramphenicol for 48 hours, and that will help to soften that staining up. So it's like a bit of a stain on the eye. And then they would go to the eye clinic and have that removed. And I haven't seen it done, but I believe it's like a little Dremel tool that they sort of just scrape, it sort of scrapes off. Sometimes you will find that they'll get to the clinic and it's gone because it's been softened up so much that it's just come away from the eye. But rust rings, and often these are people who come, you know, and they say, well, I had a you know, a bit of metal fly into my eye 2 days ago, and then more often than not there is that little ring of rust there that's formed. So the other thing with red eye is your subconjunctival, subconjunctival hemorrhages. Can be spontaneous, and it's just a little burst blood vessel, underneath the conjunctiva. Looks very dramatic. If it is due to trauma, you need to just assess, what the mechanism was. It could be that there's risk that there's a more serious injury going on. So quite often you'll find people say that they've sneezed, and then or coughed, and they've just had this little burst blood vessel. It can just be in one small area, or it can sort of spread a little bit over time, makes it look quite big, and sometimes you can end up with the whole sclera looking very, very red, and it just, like I say, it looks very dramatic, but it's usually nothing to worry about. You would consider maybe checking for raised blood pressure, and also you need to consider if the patient's on anticoagulants or have a clotting disorder. You probably would need to run that past one of the medical staff, really.
I always check as well for the posterior, to make sure that behind it, that it isn't coming from further back in the eye.
Yes, yeah. So I've got some slides after to show how it might look a bit different if it was coming from elsewhere. So babies and children, consider non-accidental injury, petechial hemorrhages with shaken babies, and things like that. So you need to consider these things as well, unfortunately. So you can also get, quite nasty red eyes that are due to chemical eye injuries. Again, it is check your history. This is an emergency. It's a sight-threatening injury, and that needs immediate irrigation and referral. And as you can see there, the redness there is looking quite nasty. So that could be another reason why somebody might come with having a red eye, but there often is a clear history that there's been some sort of chemical cause. I'm not going to go into too much detail on the injury side. I believe there is a session that went through eye injuries, very good presentation if any of you are members, that you can pick up to look at the injuries to eyes. So this is an infection of the cornea, and it's caused by some sort of microscopic organism called the Acanthum amoeba. So yeah, and it's commonly found in bodies of water, lakes, oceans, rivers, and can also be found, if you swimming pool, hot tubs, etc. So all these hot tubs that are now coming around Britain, that's replaced the trampolines, so we'll have hot tubs instead now as the children have grown up. If you are you don't put your head under the water, really. Try and try not splash it in your eye. You could get lovely bugs from your hot tubs. Yeah, so that's just not very nice looking eye there, is it? And again, you would treat that with chloramphenicol. So this is another one, a tapeworm. And I couldn't get the picture, probably doesn't do it justice, but some of them on the web when I was Googling were really vile. But you can just see something going on there in the eye, and that's been caused by a tapeworm. So hopefully not something we're going to see in our walk-in centres and minor injuries and EDs, fingers crossed. So red flags: if you have an unwell patient with a high temperature, you know, you need to look for signs of, you know, if they've got an infection, is this, you know, the patient becoming septic, are they unwell with it? Signs of cellulitis, you know, we don't want to end up with patients that have got really nasty bacterial conjunctivitis, etc., you know, it going on to orbital cellulitis. If they've got visual disturbances or loss, so we're not so much talking about that you know, it's a bit watery and they can't quite see properly. That's why we need to make sure when we're doing our visions that we are doing the pinholes to try and filter the light. But if they've got you know, a really loss or a low reading in comparison to the other one, or they're complaining of floaters, etc., then that would be a red flag too. Reduced eye movements, because that means that there is maybe some swelling, you know, inflammation of the globe itself, and that which is preventing the movements. And also, you know, with that, if there had been trauma, you might be thinking about you know, the nerve damage or fractures that can trap the nerves of the eye and prevent the movements. Headache and vomiting, as we were saying before, you know, that could be due to the angle glaucoma. Photophobia. Babies under 1 month, we did mention earlier as well, with you know, making sure that they haven't contracted something during birth, and you know, the recurrent not responding to medication. Immunocompromised patients and those wearing contact lenses are of higher risk of you know, developing the keratitis and complications with them. You know, leading to problems with their eyesight and certainly you know, ulcers. And like I was saying earlier, you know, patients with existing eye complaints, or if they're blind in one eye, then we need to really be more cautious with those patients and maybe treat them a little bit different and refer them anyway. So I'm going to go on to talk about the external red eye now. Has anyone got any questions on any of those slides, or anything to share, or you know, information that I've missed? No, we're all good. So you will get patients that'll come in and particularly sometimes if they've been telephone triaged and they're explaining that they've got a red eye. And it's not a red eye as we would think of, because it's not actually involving the eye itself. It's more to do with the external red eye. So you'll come across these as well. So it's important to, you know, to recognise these two. What can happen is, you know, because of the inflammation they might have to the lash, to the eyelids, or maybe an injury, then it can lead to irritation to the actual eye itself, and the sclera can then become quite red. And so it can develop into, you know, a red eye conjunctivitis, if they've been playing with it, bacterial conjunctivitis, and they've introduced infection, but it's usually secondary to the actual original complaint. So it's always, again, you know, your history is really important there, because you want to make sure that there's something else that's going on. So the first thing we'll just look at, where you get a bit of a red upper lid, which is a bit swollen there, is your blepharitis. And this is the caused by the oil glands that get blocked. And it can be resolved by good eye hygiene. So you can be washing with warm water. What can be quite good for this, baby shampoo as well, because it helps to break down any crystals that might have formed on there as well. It can look a little bit like dandruff on your eyelids there. It can be chronic, or you know, it can just be a one-off. So if it doesn't resolve with these simple measures, and it's quite persistent, then you can consider antibiotics for this. So that's quite a nice little slide that I found there that sort of explains that to you quite well there. Let's let you look at that. Okay. So this is the different types of styes you could get in the eye. People will come in a little lump, and although this is external, it can lead on to a bit of irritation of the eye and a bit of redness because they play with it or it becomes sore. So we have there the external hordulum, which is mostly found near the eyelash follicle. So we've got an example there of an external one and an internal one. So it sit on the outside, and then the internal one would be more in the lashes itself, more in the eyelid rather than on the outside. And you know, if you might see a little head on it as well. So it's telling us that, you know, it's caused by bacterial infection at the root of the eyelash, and it's quite tender, swollen, and you apply warm compresses, and it would hopefully just kind of drain on its own. So there would be no need there to you know, give any treatment other than warm compresses to try and draw that. We've then got a Chalcyon, which is a little bit different. This is a blocked oil gland, and it's quite firm. It's a lump there, and it's usually in the upper lid. And again, warm compresses, but this will probably require antibiotic drops. And also they can be incised and drained if they become quite inflamed and painful. They can become quite big and hard and painful, and they would then need some surgery. Dracacitis, it was infection of the lacrimal sac, which is, you know, in the lateral aspect of medial aspect of the eye with the you know, the tear duct there, and that would be if it's quite early on and it's a bit inflamed and red, then you would give the coamoxiclav and hope it would settle. But after that, then if it's getting to looking quite angry like this one, that would be a referral as well. Whoops, all right. And then you can have irritations to the eye that can cause the sclera to be red because trichiasis, which is inversion of the eyelash, and that tends to the eyelashes curl in and irritate the eye. So that's something else that you might see people coming in with. I've actually saw a gentleman today who'd had surgery for this, and had basically had his eye lashes removed and sewn back up. I believe. Haven't seen the surgery, but he'd had that done a couple of days ago, and it had come back with some pain. This can also be caused. If it's caused by a bacteria, and I don't know if you tend to see those adverts on telly where they're talking about trichiomosis, I think it is, rather than the trichiasis, which is caused by a bacteria, and it can cause blindness if it's not treated, it tends to it can be quite a simple treatment with eye drops, but it can go on to cause quite serious things. Then we've got the orbital cellulitis. So, you know, if you were triaging somebody over the phone and they were to say, you know, they've got a red eye, this is the difference. You know, this is the importance to be able to make sure that you're talking about the same thing. This is obviously a serious infection to the eye, which can you know, spread to the brain and you know, be fatal, and that's quite you can see there's quite a lot of swelling there as well, and it's quite red and looking quite angry. So, and this would you know, always be a urgent referral. Patients will feel quite unwell with this as well. So we can have some direct trauma as well. You know, and this person here has got quite a black eye, but you know, initially it can look quite red. you would be considering you know, eye lacerations and the surrounding structures as well, you know, the facial bones, and also thinking about head injury, this one. So you might be looking for a hyphema, which is blood, as you can see on this one here, that has settled in the anterior chamber, and that's an indication that there's something more going on, you know, there's been trauma to the interior chamber of the eye, and it's settled here. And again, this is a hypopum. I can never say that word, hypopum, I think. Popium. And there's pus there that has collected again in the anterior chamber there. So, like again, I said, you know, you'd be thinking about the mechanism of injury and thinking about other causes, you know, the possibilities of fractures, etc. And also, you know, you maybe think about domestic violence and POVA and safeguarding and things. I don't tend to look in the back of eyes. Some people may well do, but that's something that it's not done in our department by the EMPs. But with this type of thing, then you would definitely need somebody to be examining the back of the eye there to check for any damage. And then we can see conjunctivitis, which is secondary to other illnesses. So in the first one there, we've got molluscum, which can cause irritation and inflammation to the sclera if it happens to be, you know, on the actual eye lids themselves. And then we see you know, dry eye syndrome in some autoimmune diseases such as Sjögren's, and that causes the dry eye and inflammation. So they can be secondary to other illnesses, and then you would treat you know, the symptoms to relieve the symptoms, really. So that's what you might see as well. And I think I've come to the end, really. Maybe others that you know about that I haven't discussed, or things that you've seen, or things that I maybe haven't considered. So, you know, if there's anything you want to ask or anything you want to add, or if you've got, you know, better existing knowledge than me on some things, then, you know, please feel free to chip in. That would be fantastic. And just some useful reading there for you.
Any questions for Sandra? Any comments or words of wisdom? Fabulous, thank you, Adam. You enjoyed the session. To Mark is left, so okay, you still there, Maggie? Okay, can I just say thank you, Sandra? That was a fabulous session. Really enjoyed it. It was good. Maggie's got a thumb up now.
There's quite a lot with the red eye, but like I say, you know, patients do come in and they say, well, I've got red eyes, and they're not red eyes as we would classically think of them. But like I say, you know, I'm learning still as well. There's things I'm coming across all the time. I've been a nurse practitioner for 15 years now, and there's still lots, you know, I don't know, like the you know, the glaucoma, not really come across them much, you know, so it's always good if other people have got a bit of knowledge they can chip in as well, because it's helpful.
Yes.
But yeah, if there's any questions at all, I'll do my best to answer them.
No questions for me, but really interesting. Thank you. I'm going to go and boil an egg now and go and
okay, go and have a practice.
Yeah, practice.
It does work really well. And if you can set up a contraption so that you can put it on your slit lamp. Mark, we do sessions once a month for that are open to everybody. It's always on the first Thursday of the month, and you'll find them on our website. It's on the home page that people can come into. Okay, I'll stop recording now then.